Good morning from PQA Studios in Alexandria, Virginia, and welcome back to the 2021 PQA Annual Meeting. I am Lauren Kirk, PQA Senior Director of Strategic Partnerships. We had quite a day yesterday with Micah's Town Hall and the Innovation Theaters, and today we'll continue that trend. Today's schedule includes this general session, 9 focus sessions, time for you to connect with PQA's performance measurement experts, a quick musical interlude with one of Micah's favorite country music artists, and the opportunity for you to mix and mingle with PQA's board members and staff in our virtual reception rooms. All of our sessions are being recorded and will be made available at the conclusion of the meeting. So those of you that are seeking continuing education credit, you'll have 30 days to claim your credit through the online meeting platform. Let's review a few notes to help you navigate the meeting's platform. Learn more about each session and build your schedule through the All Sessions tab. You can save sessions to your meeting schedule or to your personal Outlook calendar. Visit our sponsors at the Sponsors tab. Each of our sponsors will have their individual profile where you can learn more about their innovations, schedule and join an instant virtual meeting with them, and send messages to connect. And speaking of connecting, you have the Attendees tab, which enables you to schedule an appointment to chat with your fellow attendees and PQA members. Click the Game tab to see how you can win fabulous prizes by engaging with your fellow attendees and our meeting sponsors. During sessions, you as attendees can engage and collaborate by asking questions and chatting. But if you encounter any connectivity issues or technical difficulties, please contact us at registration@pqaalliance.org. And finally, take part in the conversation on Twitter using the hashtag PQA21. Thank you to all of our sponsors and supporters that help make the PQA Annual Meeting possible. These organizations are leaders in quality and committed to supporting programs and initiatives that are aligned with PQA's mission. Thank you for your sponsorship and support. Now let's hear from this morning's general session sponsor, DocStation CEO Sam Andrade. Sam?
Thanks, Lauren. We're honored to sponsor this year's annual meeting and support all the great work PQA is doing to move our profession forward and promote innovative models in patient care. For the last 5 years, the team at DocStation has been building the software platform to run value-based programs at scale. We're thrilled with the progress and partners we've made along the way. Working with the most innovative payers and pharmacies to improve adherence, reduce hospitalizations, and address social determinants is extremely rewarding. We look forward to expanding on this important work with more of you in the near future. It's been a rough year. Thank you for all you have done and continue to do for your patients and members, day in and day out. I hope you're staying safe and sane and look forward to spending time with you in person at an upcoming PQA event or over some barbecue next time you're in Austin. Enjoy the next session, take care, and see you soon. Back to you, Lauren.
Thank you, Sam. Now let's get into the program. Amanda, the virtual microphone and platform are all yours.
Good morning, everyone, and welcome to the first general session of the 2021 PQA Annual Meeting. In this session, we will discuss health equity through the lens of medication use quality. My name is Amanda Ryan, and I am Director of Education here at PQA and will serve as the moderator for this session. There are tremendous health inequities in the U.S. care system, including in the use of medications, but healthcare organizations are increasingly making health equity a strategic priority. We will explore the barriers that lead to unfair and avoidable differences in health outcomes and how we can overcome them. You will hear perspectives today and experiences from a patient, a pharmaceutical company, and a health plan. In the latter part of this session, we will consider ways for stakeholders to work together to address inequity in medication use quality and support the best possible outcomes for all patients. First, I would like to welcome to the conversation Aberdeen Allen. Dean is a research chemist who lives in New Jersey. He has lived with rheumatoid arthritis for over 15 years, and his experiences led him to his involvement in patient advocacy. He currently serves as a peer coach for the CARE RA program, helping patients understand the role of RA and the heart. Dean is involved as a patient partner with Creaky Joints and in a variety of settings, including health research, health policy, and medication education. Welcome, Dean, and thanks so much for joining us today.
Thank you. Thank you so much. Thank you so much. I'm very excited to share my story and have a great conversation.
All right, sounds good. Let's start with your journey in rheumatoid arthritis, Dean. Can you tell us about that?
Sure. So my journey is a very interesting one, and it started about around 2011. I was training for a triathlon and was just really going through, and all of a sudden I had a hip injury and it just wouldn't heal. And so I went to a doctor, went to my primary care physician, and we started to try to map things out because there were other issues that were going on. So we sat down on the whiteboard and we connected the dots, and he said, I think you need to go see a rheumatologist. So prior to all of that, I was misdiagnosed for about, I would say close to 3 years. I was having a lot of issues with pain, joint swelling. I had gastric issues. There were a lot of things that were going on. So it was just a real journey up until that point where my hip was sort of the defining marker for me to really go get looked at. And once I did go to a rheumatoid arthritis doctor, that process was extremely interesting, and we're going to go into that a little bit more detail. But through it all, I've had to go through several doctors, really had to work hard and become my own advocate because of the issues that I experienced while getting the proper treatment that I needed for my rheumatoid arthritis.
So as a follow-up to that, then it sounds like the first rheumatologist maybe wasn't the best fit. Can you tell us a little bit more about that experience and what it's like working with your current rheumatologist?
Yeah, so that's a great question. It wasn't a great fit at all. So when I went to my first rheumatologist, he just didn't listen to me. I was in excruciating pain. Joints were swollen. I was just having a lot of issues. And I went there seeking help and really wanted to figure out what was going on. You know, being a scientist, I did a lot of research on my own, and I was like, well, I think I might have this. And it was just a real contentious sort of arrangement between the two of us, excuse me. So at that point, he started me on medication, and it just wasn't working. I just kept on going back to him saying, hey, doc, it's not working. Can we try something else? He just was very dismissive, really wouldn't listen. And the progression of the disease, even on medication, was still getting worse. So at that point, when I discovered that I needed to have my first hip replacement, I was very fortunate to find another rheumatologist. And when I had my first appointment with her, I was a wreck. Mentally, emotionally, physically, I was just a wreck because I didn't know what was going on, really. I had the pain in my hip. And when I sat down with her, I was expecting the same treatment. And to my surprise, and which really broke the ice and really let me know that this was the one for me, was that she stopped and said, how are you doing emotionally? And that just blew my mind because no doctor has ever asked that. No doctor really gave the indication that they cared. And this was the first time I really felt that I had a doctor that cared. And you know, I literally broke down at that point. And, you know, it was like, oh my gosh, little weepy eyed and just like, oh, I'm struggling. It's really hard. And she took the time to listen, and she was like, okay, let's pause for a second. Let's talk about where you're at, and then we can go into the treatment plan. So it really gave me a time to just share where I was at, what was going on, really got to give my perspective of what was happening. And then from that, after that, we really started to work on a plan. And even the first treatment plan that she prescribed for me and gave me, that really didn't work. But because she opened up the door, it really gave me the opportunity to go back and say, Doc, you know, this isn't working. Can we try X, Y, and Z? Or what do you think we can do? And from that point, we switched medications. We tried that for a time period, came back and said, that's not working. Then we switched to another medication and a different treatment plan. And from that moment on, it's been really great. And, you know, one of the things that I look upon my current rheumatologist as, she's like the conductor. I look at this whole ride as a train ride. I'm moving forward, I'm going well, everything was going great. But she's the conductor. She will tell me where to get off on the train, and I'll, you know, go to different doctors. If she doesn't know the answer, she's the first I don't know. And she'll say, well, I have this person, go see this person. I go and see this particular doctor, and then all of a sudden everything is better. I get back on the train and we're going together, and she's telling me where to go. And it's been a great relationship. So I think the biggest, you know, take home from this is just having someone that listens and cares. That's the biggest difference between the two doctors.
So someone that listens and cares. Yeah, absolutely. Thanks for sharing that, Dean. It sounds like communication was so much better with your current rheumatologist, and that's made a big difference for you.
It's been a tremendous difference. Someone who listens and cares and actually says, I don't know, and gives me the answers through other doctors. That's the thing that blew my mind, because, you know, the first doctor I had, he just didn't want to, you know, he pretended like he knew it all, and it didn't work. And the fact that, you know, I told my doctor, like, you're the conductor. Where do I go? You just send me in the direction I'm going to go. And that's really been a huge difference.
Fantastic. Well, thanks for sharing that with us, Dean. I would like to welcome also to the conversation today, Lori Hall. Lori is the Director of Global Health Literacy at Lilly. She's a registered nurse by training with over 30 years of healthcare experience in the clinical setting, as well as in the diagnostics and pharmaceutical industries. So currently, Lori's role is focused on advocating for the health information needs of patients. Her vision is to drive organizational change at Lilly and to enable health literacy to become a company value that is hardwired into all aspects of communication with patients. Lori, thank you for joining us today as well.
Wonderful to be here.
So can you tell us what that looks like? We're talking about hardwiring health literacy into communication at Lilly. What does that look like day to day, and how does that benefit patients?
Sure. I think it's probably starts with our company's purpose, and that is to unite caring with discovery to create medicines that make life better for people around the world. But if patients can't access our medicines or don't understand what our medicines are for and how to take them as prescribed, then they can't experience the full potential of what that medicine can offer to help them manage their condition or make their life better, really. And ultimately, the value of our innovation just gets lost. So, as you can imagine, trying to hardwire anything into a large global company of, I think we have 35,000 plus employees is a really, really lofty goal. But when it comes to health literacy, I think it just starts with a vision and a passion. And our vision really is to engage and empower patients through clear communication in order to improve patient outcomes and experience. And we have, to make this memorable for employees and easy to understand, we've made our mission pretty simple. It's clear communication, every patient touch point, every time.
So Lori, I like what you point out. Whatever treatment we're talking about, with medication in particular, it doesn't matter how good the treatment is and how much it could help people if we aren't communicating appropriately and helping and making sure patients can understand how best to use it. So that's such important work you're doing. So Dean, I wanted to go back a little bit. Before you were diagnosed with RA, your symptoms became so severe that you needed to seek emergency treatment for those symptoms.
Right.
Can you tell us what that experience was like for you?
Yeah, sure. No problem. So there was a time period for about 3 years, as I stated earlier, where I was undiagnosed and I was having really bad gastric issues. So at first my doctors thought I had either Crohn's, UC, or some type of IBD, because it was just many trips to the bathroom, lost a lot of weight. I had all the symptoms of an IBD. So at first, they gave me some drugs. I thought that was it. Everything seemed to work out. Then they took me off the drugs after my first colonoscopy, and then the symptoms reappeared, and they came back with a vengeance. So at that point, I was at work one day, and all of a sudden, I just doubled over in pain. It was just my gut was just burning. It was just a very, very bad experience that day. So it said, hey, I have to go to the ER to go get looked at because I just can't. This is just ridiculous. I can't take it. So drove myself to the ER. I get there, and to this day, it's a little funny now, but when it happened, it was just like mind shattering. So I'm there in the ER, they're checking my gut area, and they press a spot, and I'm just like, oh my God, it just felt like somebody punched me in the gut and just had extreme amount of pain. So I said to the doctor, I was like, listen, I typically don't take pain meds, but I just need something to take the edge off. So he said, okay, stepped out of the room for a second. And then while he came back, he also had a team of doctors that were with him, and they were standing close enough so I could hear them. And I heard him say, I don't know if this guy's really being serious or not. I think he's drug seeking. So I'm just going to tell him to go to his primary care physician to get his medication. And, we'll just, we'll release him and say there's really nothing much they can do. So when he came back into the room, that's what he said. And to my surprise, I didn't know what to do at that point. I really didn't want to cause a scene because it would have been this really contentious battle, I believe. So I said, fine, okay, no problem. I called my primary care physician, spoke with him, and he was going to prescribe some pain meds just to get me through the week. I was extremely, extremely fortunate that the following week, I had my scheduled colonoscopy just to figure out what was going on. So I had my colonoscopy. I went there, and, the nerd in me wanted to see like what was going on the inside. So I asked the doctor if he could twilight me, and which he did. And I was, awake enough to see what was going on. And as the camera was going in and they were looking around, all of a sudden the doctor was like, that's your problem. And there was a patch of about 6 to 8 inches that was, ulcers or bleeding. It was just like really bad. And he's like, there's the problem. And so, I said, is there a way to take pictures? I just want to have it because I wanted to show my doctors and also go back to the ER and let them know that, hey, I wasn't drug seeking. So he was able to take pictures, and I went back to the ER and said, hey, can I talk to whoever's in charge here, and explain to them, I was here last week. I was there for care. Your team thought I was drug seeking, And I showed him the pictures of my colonoscopy, and the look of horror that came over his face, it was just like, oh my God, we screwed up here. And I'm quite sure he had other words that were going on in his mind. But I said, listen, I'm not here to cause any problems. You know, not every African-American male is coming in drug seeking. I legitimately had a reason to be here. And for whatever reason, you guys thought I was drug seeking and really didn't give me the treatment that I was looking for. And here you can clearly see that I did have a problem. It was there. And, and I was truly in need of treatment. So profusely apologize. I guess they, a couple of weeks later, I got a follow-up meeting. Everybody sat down, apologized, said, oh, I'm sorry. And I'm like, listen, I don't care about that. I'm here to teach. It's a teaching moment for everybody. That's the one thing I wanted to walk away from. It's a teaching moment. I'm not here to cause a lawsuit or anything like that. I got the treatment that I needed. Now, every time I go back to the ER, I joke with my wife and I say, I think I must have a gold star next to my name, because every time I go in, I'm immediately whisked to the back. I get, the greatest care possible. And, and it all worked out in the end. But it was just it was challenging to go through that. And it just taught me a valuable lesson that anytime and every time I go to the medical or any type of doctor, excuse me, I have this is literally my medical Bible that I go and I carry in and I show doctors, hey, this is what I'm going through. This is it. Here's my latest results. Here's this, here's that, just to avoid that situation happening again.
So a teaching moment indeed. Thanks for sharing that with us, Dean. Lori, I want to turn to you. And, the story Dean is sharing with us here, unfortunately, this is all too common. He is certainly not the only person to face difficulties like this. Can you tell us a little more about how Lilly is looking to address issues similar to what Dean is facing?
Yes, absolutely. And unfortunately, Dean's story is probably not a rare one. And I think at the core for every human being, everybody wants to understand and feel understood. And so that really is the core of what health literacy is all about. So we know that health literacy has a disproportionate impact on groups that are underserved and at risk for certain health outcomes. And some of the ways that we're addressing this inside Lilly is to educate teams, like our patient support programs, our patient education teams, our patient assistance programs. And we educate them on the link between health literacy and the social determinants of health. Those are the conditions in places where we live and work and learn and play that actually shape our health for everybody. And what's remarkable is that we know that the research tells us that social determinants account for about 80 to 90% of health outcomes, like how long you live or the quality of your life. And medical care only accounts for about 10 to 20% of health outcomes. But the good news is that health literacy is a factor we can change. So by taking steps to communicate clearly, which includes active listening, we can help reduce health disparities and better serve everyone. And so by recognizing that we all play an important role in improving health literacy, we've also leveraged our experience and expertise in this area with a health literacy and clear communication training program for providers and payers too. So whether they help patients enroll in health plans or create or are selecting patient education materials, or they're working with patients directly, this training actually offers scenario-based activities and strategies that they can use to communicate clearly with the patients that they're working with. And both of these training programs include a reference to the Health and Human Services National Class Standards. And class stands for the culturally and linguistically appropriate services. And basically, these standards are intended to help advance health equity, improve quality, and help eliminate healthcare disparities by establishing this kind of like a blueprint, really, for healthcare organizations by providing effective and equitable, understandable, and most importantly, respectful quality care and services that are responsive to cultural beliefs and practices and a patient's preferred language, health literacy, and other communication needs. So the resources exist out there that help us know a better way to do this.
Absolutely. Thank you, Lori, for sharing. I hear communication as a theme again, and really wanting to be understood as a human being. That really does apply to all of us. So Dean, kind of turning back to you and thinking about these themes as we keep going. When you were diagnosed with RA, tell me a little bit how your race and gender affected your ability, especially with medications. You know, did that affect your ability to access them, to use them as prescribed? What was that like for you?
Yeah, that is a fantastic question, and so it did have an impact. You know, when I think about my journey and what I've been through, I'm big on research. I love trying to figure out what's going on, understanding things. I wanted to understand RA. I wanted to understand how RA impacted men. I wanted to understand how RA impacted African-American men. And when I started doing my research and really looking, I didn't see much. And it was sort of like an aha moment for me, like, is this something, the reason why I'm not being heard or understood or misdiagnosed is that there's not enough research, there's not enough information about African-American men and with RA. And so when I go see doctors, you know, on the outside I look great, but you know, on the inside my body's a wreck, and they're just looking at me like, you know, this guy's okay, this guy's fine. I've had doctors say that to me, like, you don't look like you're sick, and I'm just like, well, I am. You know, that's why I'm here. It's sort of duh. And the biggest thing that I could think of was that when I had my first rheumatologist and I was starting to take my meds and I didn't see results, I stopped taking them. I really, because I just got so frustrated. I didn't adhere to taking my medications because the problem was that my doctor wasn't listening, the medications weren't working, and I got frustrated. So I just, you know, I searched, like Lori was saying, I was trying to find literature that broke stuff down so I could understand it, so I could, you know, say, hey, it's okay to take the medication. Culturally, there was no one there that I could really relate to say, you know, are you having these problems? It's okay. So for a period of about, and I'm going to be very candid, for a period of about 6 to 8 months, I just was very sporadic with taking my medication. So I would go back to my doctor and say, this is not working. And then he would just shoo me away saying, oh, your numbers are fine, but the symptoms were still present. I said, oh, I'm going to try fish oil. I'm going to go to acupuncture. I'm going to try this. I'm going to do that. Went to a second medication, had a really bad allergic reaction to it. And once that happened, I was like, nope, I'm not taking it anymore. And so it was just because I didn't have the literature, the understanding, and the teamwork with my first rheumatologist. I be very candid, I'd stopped taking my medication. And it wound up hurting me more than anything else because the disease just kept on progressing. And it wasn't until I sat down with my second rheumatologist, and she took the time with me. She brought out the literature. She explained stuff. She was saying that, you know, this is how long it's going to take. This is why it's going to take as long as it does. She was really mindful and respectful of what I went through with my prior rheumatologist, and just really took the time to explain it. And most importantly, she was on me. She kept on every time I would see her. Are you taking your meds? Are you doing this? I see that you haven't refilled your prescription. What's going on, Dean? Oh, okay. I'm going to take it more. I'm sorry. And once I knew that she was checking to see if my prescriptions were being refilled, we had this great dynamic working together, it really got me back on track with taking my medications on a timely fashion and making sure that I was on it. And to Lori's point, having the literature, that to me was golden, because I'm one that will read, try to understand, get all the information that I can, and just say, all right, I'm good. Let's keep it moving. Let's keep the train going. So Lori, thank you.
We appreciate your honesty, Dean. Stories like yours are so important. And I'm going to turn back to Lori now and talk a little bit more. You talked earlier, Lori, about helping employees to understand what health literacy is. I wanted to see if we could talk about a little more specifically connecting it to equity. So how do we help all patients? Regardless of background, regardless of, the situation, social determinants of health factors that we're thinking about, how do we get the information they need in the way they need it and when they need it? And how do you work on that?
Sure. And what's so great about our conversation today is we're really highlighting the two-sided nature of what effective communication is all about. And it really is about patients and providers having productive conversations. And that can only happen with trust and with clear communication and empathy. And I think Dean's doing a fantastic job of sharing the patient perspective and how you have to advocate for yourself. And I'm hoping I'm shining a light on the healthcare system side of things and the huge responsibility that we have to meet patients where they're at. And so one of the ways that we've done this at Lilly is by, first of all, just creating this sort of health literacy center of excellence that's accessible to employees worldwide. So it's kind of like a one-stop shop, which includes interactive tools and resources. We have something called a health literacy playbook. We have a plain language thesaurus, which helps translate really highly technical medical jargon into more friendly language. We have a health literacy scoring tool, some real Lilly before and after examples, and links to our training. And all of this revolves around a core set of 8 health literacy principles at Lilly. But sort of at the core of this training, there are ways we can do better in terms of how we verbally communicate with patients and how we communicate more effectively in writing. And so when we're talking with patients, I think it's critically important that we acknowledge that most people at one time or another struggle with health literacy, and you really can't tell just by looking at someone if they have, what their health literacy skills or abilities are. It's very situational. So we encourage this universal precautions approach, which means we assume that health literacy is a challenge for everybody, so that we seek first to understand. One of the great tools, and it's so easy, that providers can do is with any new encounter with a patient, whether it's a new encounter or a follow-up, but is to ask that open-ended question: what is your understanding of your condition, your medicine, your treatment, your upcoming surgery, whatever that might be? And by asking that open-ended question, what you get back gives you a wealth of information Some patients may have incomplete understanding. Some may have it completely wrong. In Dean's case, it was not only did he understand it, he could articulate it really well. So that would be information really important for his early physicians to understand about him. And then it's about focusing on the need to know information and not sort of piling on stuff that's not important in this moment. It's about using what we call plain living room language. And then the importance of what's called teach back. So if you've shared some new information and you want to make sure someone has took it all in and really understand it, because it's overwhelming. Teach back is that quick tool that you can use to check for understanding. It's not quizzing the patient. It really is testing your communication skills as a provider. And so it's framed in that way. And then when it comes to creating written materials, it's really not just about plain language, or a lot of people hear about just the reading grade level. Oh, we write everything to a 6th grade reading level. That's good enough. Well, it's not good enough, actually. It's also incredibly important that you choose culturally familiar language and examples. So use examples of activities and foods and experiences that are familiar to the audience that you're trying to reach. Choose names or images, photos that represent your audience's race, ethnicity, their age, their gender. Those slick magazine photos, most people can't relate to. They want to see real people. Make sure the audience is broad and you choose examples and images that don't really exclude anyone. But the most important thing is to test material with members of the target audience. So plain language, if following plain language, writing principles and validated readability scores can't replace a patient's lived experience with a condition. So wherever you can, partner with patients to help co-create that content. And I'll just end by saying that really the bottom line is that addressing health literacy has a real impact on health disparities and medication use quality. And when patients can access and understand the information they need, they're more likely to stay on their medicines, right, Dean? Take their medicines as prescribed, use injection devices the right way. They know what side effects to watch for and when they need to call their doctor. And ultimately, they can avoid hospitalizations and other negative health outcomes. So that's the importance. Health literacy is something that's sort of hiding in plain sight and easily overlooked, but has critical impact on patients and the kind of care they receive and their ability to understand and participate in their own care.
Absolutely. Thank you, Lilly, for sharing those examples. We appreciate it. I wanted to just turn back to Dean for the last minute or so that we have to end out this segment. So being an African-American man with RA compelled you to share your story with others. And of course, we're privileged to have you sharing it with us today. Do you have a couple of key takeaways for our attendees before we wrap up?
Yeah, sure. So the biggest, there are a couple, but the biggest one is to have people listen. That's the biggest thing. Listen to your patients, listen to the stories, because as they share, you're going to gain a lot of good points that you can jot down in the notes, or you can remember about your patients. So as they're going through the process, you'll be able to connect with them all, because that connection is very key. And African Americans, Latinos overall, there's distrust with the medical profession. I mean, let's be honest. And so the more you can really break that wall down, the better off not only will the doctors be, big pharma, but the patient. And that's the ultimate goal. The patient is the one that we want to see have a better quality of life. Encouraging people not to give up. I've gone through many doctors. Nope, you're fired. And moved on to different doctors to really have my team now. And I call them my dream team because they are on point. When I know that I have a problem, I can call them up and I can get answers right away. If they don't have the answers, they can call somebody else or refer me to someone else that I can get the information from. Lori was so spot on towards the tail end of what she was talking about. There has to be more representation of people of color and trials and research ads. One of the groups that I work with, Creaky Joints, we just finished up a campaign where they were sending out some literature, and the first round that they sent out or gave to us to review, it was horrible. And they even knew it was horrible because the pictures, the stories, everything that they had just did not connect. And when I looked at it, I was like, no, I don't see me in that. That's not me. What do you suggest? And we gave suggestions. And then when we finished, the finished product was spot on. And when they sent it out, the response that they got was so great that they were saying, okay, we need to do this more. TV commercials, I don't see me. I just don't connect. I'm looking at it like, I mean, I know the drugs work and I'm not going to take away anything from it, but I just don't see me. So I'm just like, okay. And the unfortunate thing is that I have friends who, a couple of friends who have RA and a couple of others who have other autoimmune diseases. And when they see these commercials, they're just like, that's not for me. And I'm like, no, it is for you. No, trust, it is. It is. It's really for you. But, you just have to get over the fact that there's no representation. There's no one there that we see. Just really, and the key point and the main reason why I'm really speaking out more about this, Amanda and Lori, is just to really get more representation of people of color in research. That to me, that's the driver, because if we can tailor questionnaires, research, things of that nature, literature, it only helps your organization, it helps Lilly, it helps so many other people, because now they're getting the wealth of information that they need to design better drugs, to come up with better questionnaires, literature. Your organization can work with doctors and big pharma to really drive home the point of designing different things to help people with the quality of life. So my take home is that to really work hard and diligent to get more people into research, more people into trials, more people into helping design literature, so that people like myself and others, as we continue to journey, we are represented, we are heard and understood, and it will help doctors and everyone else to help us with a better quality of life.
So designing a better future through inclusive research and
Yes.
including everybody in the conversation.
Most certainly, because I guarantee you, once you start doing that, it's a win-win for everybody. And that's it, bottom line, it's a win-win.
Fantastic. Thank you, Dean. Thank you, Lori, for joining today for the conversation. We will see you back at the end of this session for live Q&A with the audience.
Great, looking forward to it.
Next, I would like to introduce Sharon Jhawar. Sharon is a member of the PQA board and the Chief Pharmacy Officer at Scan Health Plan, where she optimizes prescription benefits in clinical programs. She provides direction on the development of innovative pharmacy care programs that ensure safe and appropriate member medication use, and she manages contracting, oversight, and compliance of pharmacy benefit manager operations. Sharon works cross-functionally to help drive SCAN's overarching organizational goals of person-centered quality care, growth and retention, operational excellence, strong CMS star ratings, along with a positive member experience. I will now turn the floor over to Sharon, who will share about SCAN's work to address medication adherence by viewing it through the lens of health equity. Sharon?
Perfect. Thanks, Amanda. And let me start off by saying that that was a great conversation that you had with both Lori and Dean, touching on so many important elements. And a couple of them that kind of stuck with me was, first and foremost, not everyone can be their own health advocate and navigate the healthcare system like Dean has been able to do, albeit at times very difficult for he himself. And then as I listened to Lori speak, we know that in healthcare, no matter where you are, whether you are in pharma, whether you are in the healthcare delivery system or an insurer, we are all looking together to get better at helping patients navigate their care, improve health literacy, and reduce health disparities to ensure that there is equity for all. So kind of building on that dialogue of what patients like Dean experience, and the importance of improving health literacy, which Lori spoke about, they're weaving into the DNA of their organization. I kind of want to share a little bit about our journey at SCAN Health Plan in addressing health equity and the disparities that we saw in medication adherence. So just to provide context to folks joining in today on SCAN Health Plan, so you just have a sense of how our organization may be similar or not so similar to your own organization. We are a non-for-profit organization, Medicare Advantage Plan, and we serve about 220,000 older adults. And our sole focus and mission is to keep them healthy and independent. That simple. We were actually founded by a group of senior activists right here in Long Beach, California. And they were kind of angry back in the late 70s that their medical care and their social care was not coordinated. So they themselves formed Senior Care Action Network, now known as SCAN. And in our kind of infancy, we were a 28-year social HMO demo with CMS. And so as you can imagine, our structure incorporated a lot of social workers, and it still does today, helping folks navigate their care and their benefits, like transportation, like food, and things like that. From a cultural perspective, just to give you insight on our organization, because we were in California, we are a melting pot of cultures. When we take a look at our members and the languages they speak beyond English, they are Spanish, they are Korean, they are Vietnamese, and Mandarin. And then lastly, you know, we do take pride in the fact that we are a 4.5-star plan for 4 years in a row now. But actually late last year, we took a look at our star ratings by race, our overall star rating by race. And we saw a very different picture. We did not see 4.5-star for every race. And that really spurred us to have a lot of dialogue within our organization and then to take action. And some of that I'm going to share with you today. So like many organizations, SCAN is committed to focusing and improving equity for all. For us, we ideally want to get to justice for all, but we know right now we are a ways away for justice for all, and that our first step is equity. For folks that like process and structure when they're trying to solve a problem, to share with you, we at SCAN have been keeping the guiding principles of IHI in the forefront of our thinking and our efforts. And so with us being a Medicare plan, the place where we started, and I alluded to earlier, was the star rating metrics. And we took all 45, 50 of them, and we broke them down by race to see how do we do by each individual race. And from there, as we took a look at that, there were disparities amongst those measures all over the place. And we said, hey, we do not want to boil the ocean and just throw everything at it. Let's figure out where we want to start. Let's learn in a particular area of, you know, hey, after we make some changes, what's working, what's not working. And once we figure out what's working, then we can go ahead and apply them in other areas we see have disparities. And so as we were doing that, one of the things that jumped out at us was the fact that in our Black and Latinx members, medication adherence was 3% lower. And so we all know that if you take your medications as you should and routinely, it does lead to better health in managing your chronic conditions. And so we also know there's a lot of folks that work on medication adherence. We know when we improve 1%, that's a big deal. And so likewise, when we saw a 3% lower rate in these two populations, that was like a huge deal for us. So we said, hey, let's go ahead and let's focus there first. And our first step as an organization was to kind of call it out, to say, hey, this isn't right, and our baby's ugly, and we got to do something about it. So that was our first step. Our second step was really to say, this should not exist, and we are going to reduce it by 25% this year. And we've made it a corporate incentive goal tied to every employee this year. And so we're really putting our money where our mouth is, putting a line in the sand saying this should not be the case, and we're going to do something about it. So, after that, a lot of conversation continued to say, why does this disparity exist? And, a lot of times the first place your conversation tends to go is medication cost being a main driver of it. And so what I would share is for our particular organization, our benefit design is structured so that 90% of the medications seniors take, it's available for a $0 copay, and it's been that way for years now. So for us in particular, we knew that the root causes of this disparity are something deeper than medication cost. So we formed a pharmacy health equity group, and you can see on this slide, it's made up of folks all across our organization, including our business excellence and diversity team, our network quality team, our healthcare services informatics teams, and then of course, pharmacy. In the center on our strategic approach, the center box here, you can see two elements. I discussed our approach of having corporate alignment and tying every employee's incentive plan this year to reducing our disparity that we see in medication adherence, and the fact that we have a multidisciplinary team that's ideating and now putting new things in motion, and we're just doing a lot of learning, quite frankly. And then around the center box, you see 4 process steps that we've been taking. So we really started out by gathering insight. And the most important piece was that insight directly from our members through ethnographic interviews. We also sought feedback from our providers that we partner with, our own employees, as well as other health plans. And through those conversations, our goal was, number 1, to learn and listen, and number 2, to confirm some of the assumptions that we had in our minds of how care needed to be tailored differently for these 2 specific populations. And so we're taking that insight and we're updating and making tweaks to our programs, but we're also keeping in mind, hey, we need to, at times, we might need to throw something completely out the door and redesign and re-engineer something altogether in order to better meet our members' needs. So our plan is to make refinements, have new interventions, and as we put things in motion and we find out what is working, we're going to be thinking through how to expand and scale those things. And then we're also looking at trying efforts in partnership with others. So it does take a village to tackle this. And so we're thinking about how we can partner with our medical groups, how we can partner with retail pharmacies, as well as our PBM. So this is the money slide for our organization on what we heard from interviews and what we saw in our data. And you can see in the top left box how we connect our cultural humility in our conversations. That's really one thing that jumped out at us that we needed to improve on in order to build more trust with our members. The other thing that we saw and heard and learned was that we needed to be better at building personal health literacy, which Lori talked about earlier, with our Latinx and Black members, so that they're able to make decisions for themselves that result in better health for them. And you can kind of see in the next 3 boxes is more informational data that we just learned specific to our demographics. But then at the bottom right, we noticed that we needed to do a better job, specifically with our Latinx members, in connecting them to their mail order benefit and educating them on their mail order benefit. It became very loud and clear in our conversations with our members that they just weren't familiar that the benefit even existed. Some of them didn't even know we offered a 90-day supply, let alone the mail order benefit. So we clearly learned that there was a lot of opportunity there. Another clear next step for us on the insight that we gleaned is that we needed to take the time to transform our care navigation, which we've been doing, since the beginning of SCAN's origins, and really tweak it so it's culturally appropriate care navigation. And so that was kind of more of tweaks that we've been starting to make. And so some of the elements of that are having cultural humility skills training for our staff, so that number one, they can better understand different cultures. They can understand beliefs in other cultures, as well as what the norms are. I can tell you myself, with Black History Month back in February, I actually learned for the first time, and I never realized, and especially as we are doing kind of COVID vaccine and building confidence in the vaccine, that in the African-American female community, back in history, there was, sterilization of females. I honestly never knew that. It may sound ignorant, but I learned earlier this year. And by all means, does that change me as a clinician as I'm helping someone of color? Absolutely. And so having these trainings and teaching others so that they know more about other cultures is also important. Also, based on spoken language data, we are pairing our care navigators to support our members. And I think pairing by language, it's a lot of things a lot of organizations do, right? It makes good sense. But not only that, we're actually providing our care navigators with race information, and we're going to start to actually pair our pharmacists and our care navigators by race to say, hey, does it lend itself to stronger connection in those conversations on medication adherence? So lastly, the other tweak that we're making in our care navigation is doing staff huddles, and so that everyone can share their experiences, learn from one another, and give help to one another. And we do huddles today, but it wasn't necessarily honing in to say, hey, what are the challenges you have? Or I had this patient and this is what I experienced with this member from a cultural perspective. So in addition to improving cultural care navigation, we are also looking to improve health literacy. And I talked about that earlier, that it's an area that we clearly heard we need to do better on. So we've started this in 2 ways, and this is just kind of in its beginning stages of putting more quivers in our toolbox to utilize. The first is we know when it comes to taking medications, visualizations on how you should take your medications, as well as directions in your native language, are oh so helpful. And so what we are in the process of doing is providing all of our care management team with the ability to provide this to our members using a tool by First Data Bank called Meducation. Kind of see a picture of what it looks like on the bottom of the slide. And then in addition, we thought we would try, based off of what we know in the Hispanic community, the dramas of telenovelas and how folks love to watch those. How can we take that concept of, telenovela dramas that are oh so popular? We decided to adopt these photonovelas that once again, in a dramatic format, show our Latinx members and educate them on key topics. And so the topics we're focusing in on are medication adherence, diabetes, and flu shot. So we are just at the beginning of our journey. What I've been sharing with you are kind of our beginning steps. And it's going to be a long haul journey. It doesn't end at the end of this year, but you can kind of see the tangible steps that we've put in place. to start to hopefully help reduce this disparity that we see in medication adherence. It's going to take a lot of work. We're going to be learning a whole heck of a lot. We're going to be failing at certain things, I can imagine. And our sense, at this point in time is hey, we need to also measure our performance. And so we've created a dashboard to track our performance on a monthly basis. And personally, I think this is a key step, right? We can all say we're doing stuff, but we need to know if it's meaningfully helping. And so tracking our progress, I think, is key. So kind of in a nutshell, those are the major highlights of what we have going on at SCAN as it relates to health disparities. And like I mentioned, kind of honing in first on medication adherence because we saw a big gap there. And then we plan to take these learnings and apply them to the other disparities that we see amongst other quality measures. And so I think what I'll do now is Amanda, I'll pause here and I will turn it back to you so that we have ample time for audience Q&A with Dean, Lori, and myself.
Thank you so much, Sharon, for sharing the work that's going on at SCAN and all of the wonderful examples of practical approaches that you are all doing to address racial disparities in medication adherence. SCAN is really doing great work in this area.
Thanks, Amanda.
VUCA Health has created the largest library of medication education videos for patients that can be integrated into websites and mobile applications. They've also created a way for pharmacies to provide a paperless alternative to patient leaflets and med guides. With the remaining time of this ad, VUCA Health wants to share a fun fact with everyone. Did you know the 1939 novel Gatsby is the longest book ever published that doesn't contain the letter E? The novel contains over 250 pages and 50,000 words. While it seems impossible, author Ernest Vincent Wright made it happen. The VUCA team hopes you enjoy the rest of the PQA annual meeting. PerformRx is an NCQA and URAC accredited pharmacy benefits manager located in Philadelphia, Pennsylvania. Formed in 1999, PerformRx maintains a clinical culture providing cost-effective therapies and extensive evidence-based programs at an optimal cost to its clients. PerformRx's best-in-class pharmacy benefit management services include formulary development, drug therapy management, and rebate management. Perform Specialty is PerformRx's wholly owned and integrated specialty pharmacy. Markets serviced by PerformRx include Medicaid, Medicare, commercial, and employer group. To learn more about PerformRx, Perform Specialty, and the services we provide, please visit our website at performrx.com. The Enliven Health patient engagement platform integrates intelligent clinical solutions and digital communications technologies to ensure increased member adherence, retention, and quality scores. At the same time, Enliven Health Solutions empower health plans to effectively manage risk and significantly reduce costs. A national study conducted by researchers at Harvard University, health plans and pharmacies using Enliven Health Solutions have achieved a 9% reduction in hospitalization and ER visits. To learn how Enliven Health can help you measurably improve member health outcomes and strengthen plan profitability, visit enlivenhealth.co.
With our panel. Dean and Lori, I would like to welcome you back to the conversation.
Thanks.
So our first question is going to be for Sharon. Sharon, do you see the potential for quality measures that look at demographic disparities? So as a way to incentivize efforts to improve adherence and outcomes for beneficiaries, any insights on what that might look like and pros and cons?
Yeah, I think in the Medicare program, we're headed in that direction. As a matter of fact, Mike, Lisa, Patrick from PQA, we had conversations earlier this week because there is an appetite to be able to, take medication adherence to the next level. And one way to do that is to break it down by the disparities and measure organizations by improving kind of the gaps that we see. And so I think it's going to be a natural evolution of where we go. I think that in terms of approach and, what I described in how SCAN did it, we literally took every star rating measure and broke it down as our initial step by race, because that was information that we had a lot of and most robust at this kind of time is a good first step. But I think there's multiple ways to do it. I do think that that's where we're headed.
Okay, thanks so much, Sharon. Lori, the next question is for you. Your insight into the importance of patient-facing resources is very important. What should providers do to engage patients early on in the process in order to reduce the lag time between symptom identification and effective treatment?
Oh, that's an important question. One of the things that I think about often is we all commonly use the term improve patient outcomes. But I also want to guard us in that according to who. If it's a prescriber or physician, it's typically clinical outcomes. For example, diabetes patients and getting an A1C in range. For population-based decision makers, it's, you know, those types of measures. But let's not forget that we also have to factor in what's important to patients. What does good look like for them? How do we ensure that we incorporate patients' subjective, whole lived experience perspective? Because they may or may not align with what our clinical measures are, but it's absolutely important that we listen and understand what's important to them. One of the definitions of what good looks like, I believe it's UCB who said this. I wish it was Lilly, and we're working toward this, but they define success as when we enable our patients to live the life they choose rather than the one dictated by the disease. So what's great about that is that it incorporates what's most important to patients. And so that can only happen if we listen, if we actively listen. So what that means, what that looks like is taking into consideration all the cultural factors and personal experience that weigh into what good looks like for a patient. So it's best to just learn from them, ask respectfully about their health beliefs and their customs, make note of that in their records so that that becomes an important factor in every conversation at every touch point. And I think ultimately it's something I mentioned before is it's that seek first to understand mindset that will allow us to treat patients as the unique individuals they are.
Absolutely. So important to consider each individual. And I love the philosophy around what's important to the patient and making sure we get to the bottom of that. So thanks, Lori. Next, we got a question for Dean. First, this question asker wanted to thank you for sharing your story. And I know that echoes a lot of what we are sharing with you today, Dean. So thanks for sharing your story with us. We do have a lot of work to do. So thinking about better caring for patients, and especially African-American patients, what barriers should we address first? So what's the low-hanging fruit, if you will, to help people access care, get the medications that they need, and then ultimately have the outcomes, like Lori was saying, that are important to each individual?
Yeah, so Lori hit on several key points, and the biggest one was getting to know your patient. There is the cultural barrier that exists with African Americans where we don't trust doctors, we don't trust the medical profession, we don't trust the care that they could potentially give because of the history. So the biggest piece that I believe, and I think my rheumatologist really sort of shattered was, excuse me, breaking that whole process by asking, how am I doing? And she showed that she cared. So the biggest take home from this one is that I've seen in talking with other patients who are in similar situations as myself is to really listen and learn your patient. To me, that will go miles.
All right, thank you, Dean. Very succinct and sounds simple, but definitely not easy to do. But right. So thank you for this conversation. Next question, I'd be interested in all three of your perspectives on this question. So let's run through the same order again. We'll go Sharon, Lori, and then Dean. How should the patient perspective be considered when we evaluate healthcare quality? It's a wide-ranging question, so somebody can.
Yeah, I mean, I think that the patient perspective is key and of utmost importance. And so in all of our conversations, we need to be asking what matters to the person in front of us as healthcare providers, as a healthcare delivery system, as an insurer or a pharmaceutical company. That's what matters, right? Helping them live the best life that they have. And so I think it's hugely important. I think specifically in Medicare, we're taking good steps towards that in the STAR ratings program with the member satisfaction on their care being weighted more than clinical health outcomes, right? Mm-hmm. It's weighted 4 and clinical outcomes are 3. And so I think we're taking good steps within Medicare to make the patient perspective of utmost importance.
Thank you, Sharon. Lori, what would you like to add?
I think that's fantastic insight from Sharon. And I think I'll maybe approach this from the clear communication perspective, because if you really think about it, healthcare is primarily communication based. And not all of the players who influence a patient's health status have the opportunity to work directly with the patient. But I think a big part of this is really taking the opportunity at every patient touch point along the care continuum that each stakeholder owns their part, and not assuming that counseling or education or clarification will happen downstream because I'm too busy, or we don't do that, or we don't have time for that. And so what I mean by that is things like, as Scan has just talked about, really owning all of the communication that they have with patients and prioritizing that. For pharma, we have a long way to go. That looks like things like doing a better job with easy to understand patient package inserts that are written at the tiniest font possible and add a lot of confusion and caution, really, I think, for patients. I think for prescribers, it's taking that time at the point of care to counsel patients, taking enough time to counsel them so that patients understand, leaving that appointment, what this medicine is, why it's prescribed, what the possible side effects are, what to do if you forget to take a dose, when to notify your prescriber. I think for pharmacists, it's rephrasing that sort of standard question of, do you have any questions? To just a slight rephrasing to an open-ended question of, what questions do you have? So that it stimulates the opportunity that I expect you'll probably have some questions. What are they? That means at the pharmacy level that the medication guides that get folded in half and stapled to the bag, we could do a better job of making those more health literate. And then I think probably most importantly is it's at the policy level, really, and ensuring really we are in desperate need of a standardized approach for what is placed on that prescription container label and the design of that label. It needs to be more legible, easy to understand, with clear, standardized instructions, so that there is no doubt how to take that medicine. So, example, 2 tablets in the morning, 2 tablets in the evening versus 2 tablets twice daily. Those kinds of instructions are what get patients hung up and confused. A lot of errors happen, and that's where our challenges around adherence come into play. But it's a good start toward building trust, back to what Dean was saying. And so we all have a part to play, and we need to be taking those opportunities.
Absolutely. Thank you so much, Lori. Dean, from your perspective, how should the patient perspective be considered in evaluating healthcare quality?
It should. It really should be, because, this is a tough question, because practitioners have many patients. They have, certain, window to basically get all the patients in that they need to get in through the day. But the big thing and take home that I would want people to understand is that when you take that extra 5 minutes to basically talk to the patient and say, hey, do you understand what this visit was all about and what questions do you have? And one of the things that, you know, I've been doing and suggesting to others to bring a notepad or take your phone and do a recording so that you can understand. And then there's that dialogue. And then as time goes on, that trust will be built and open communication, excuse me, will be established, and we would see better quality across the board with many patients. So, you know, Sharon and Lori hit on a lot of the big topics for this one, but for me, it's just coming from the patient, just really having a doctor take the last 5 minutes. Hey, what's going on? Do you understand? How do you take your medication? What further questions do you have for me? And make them open-ended and not so succinct where I'm shut off, but open-ended. And I think we'd see a better transition going across the board.
Yes, definitely a theme of open-ended questions and communication in that way. So thank you, Dean. We've got several attendees interested in this next question, Dean. It's related to data. So considering the limitation available on data sources for measurement, from a patient perspective, how do you feel that providers should be evaluated for quality?
I don't think that's a good idea because the problem is that, you know, if a patient has one bad visit, then it's you know, 4 stars or whatever. So I struggle with this question. When you started talking about it, I really struggle with this question because it's very difficult. I mean, I could have gone back and given my first rheumatologist, you know, horrible ratings and everything else, but for somebody else, he's the perfect match. So I really struggle with this question. And I'm going to be honest, I really don't have a good answer for this one because I feel at times it's unfair to put a quality measures against physicians when they are really trying to do the best. And, you know, the system as it stands really handcuffs them.
All right, thank you, Dean. Sharon, back to you on a different topic here. So in your presentation, you shared with us efforts that SCAN has underway to address racial disparities in medication adherence. So does SCAN have plans to go beyond racial health disparities? Essentially, what's in the future? What's next for SCAN?
Yeah, I mean, we started with racial disparities primarily because that's where we had a lot of information. Our data was robust around race and language. So that was our place to start. Simultaneously, as we're working in this area, we're trying to get more information on our members that we take care of. So, you know, getting ethnicity data, getting disability data, SOGI data, sexual orientation, and once we get more of the information, I think then we can identify, hey, what are our weak spots and where else do we need to focus? So we are looking beyond racial health disparities and as we get more information, but I really like, you know, in our conversation, how we've been saying, as we have, you know, understand each person that we're trying to help live a better life, understanding what's important to them. One of the key things we do in our care management is document all that so that we, every time, no matter what culture someone is, no matter what race someone is, we understand at the end of the day what's important to them in their life. And we're building or orchestrating care is the term we use. I know Dean used his specialist was a conductor. Our goal is to orchestrate the right care around every older adult. And so we're striving to get better at that every day.
Getting better every day. Yes, it's always a process. So thank you, Sharon. Appreciate that. We have time for one last question. I think this would be a good one to kind of wrap everything up and hear from each one of our panelists again. So this is all about working together. So if we picture, what Sharon was just talking about, continually moving towards better health equity and medication use quality, how do we all work together? We've heard 3 different perspectives. I'd be interested in what each of you think about working together and what we need to do or to have at our disposal to get there. So tools, resources, processes, what do those look like, and how do those become the standard of care? Let's start with Lori, and then we'll go Sharon and Dean to wrap us up. Lori?
Sure. This is a big question, isn't it? I think it starts with dialogue just like this. Look at us together here, coming from 3 different perspectives on a similar topic. And what's remarkable, or maybe not so remarkable, is that we all want the same thing. We're just not doing a very good job of connecting. So I think more forums like this, I think more open collaboration between pharma companies, between pharma and payers, between payers, the more that we can share the end goal of improved patient outcomes and improved patient experiences, and sharing those insights freely. For us at Lilly, this topic resides in the non-competitive space. It is that, rising tide lifts all boats. When we all do this, everybody benefits, most importantly, patients.
Thank you, Lori. Sharon?
Yeah, and so kind of piggybacking, agree with everything that Lori just mentioned. And to kind of add on to that, I think also, systemically, we have to also address the situation. And so some of the types of things, if we want providers to have those kind of quality conversations and ask the open-ended questions, we as a healthcare system have to change. And so some of the types of things are all of us, understanding the biases we all come with. So our organization is committed to training all of us to think differently, act differently. Only then can we provide better care to others by doing that. And so, having a heavy emphasis there. But I think to Lori's point, all of us conversing together helps to then identify where are the real problems and then begin to solution. To your question about the tools and the resources, you've heard some of the areas that Lori's organization, in terms of, material, improving those to help empower education on health. I shared around our universal medication schedule being in 30 different languages, those are key pieces that are going to help us, but those are, it's how we all weave it together to really help each individual care for themselves that's really going to matter. So it does take a village. It's going to take all of us to do it. And I think the key is how we all weave together to orchestrate the care around each individual.
Well said. Thanks so much, Sharon. Dean, what are your thoughts?
Yeah, so Sharon and Lori really, hit on a lot of the key topics. And for me, the biggest portion or thing is just tools around research, developing online tools for people to fill out polls, share their opinions, share their views, because the more data that's collected, the better each of the arms that we have here, patient, provider, and companies, they can all work together to really develop tools, medications, technologies to help better quality of life. Because bottom line, that's what I'm looking for. I turn to organizations like PQA and others to get information. So the more research that's out there, articles, things of that nature, the tools that I could use, one, allows me to build confidence so that I can go back and talk to my provider. Secondly, it gives me the ability to become more educated. And as such, I have better outcomes because now I can make lifestyle changes. I can do things to really enhance my quality of life. And then, the last thing is just to feel more comfortable with companies and other organizations when they reach out, because that barrier is broken. I trust that the information that I'm going to be giving about myself will be used in a fashion to help others. So, those are all the tools and everything that we have that we could really come together, marry them, and have a great outcome for patients, pharmaceutical companies, and providers for great work down the road.
Sounds like a good place to end the conversation for today. So Sharon, Dean, Lori, thank you so much for joining us today. We really appreciate having you with us.
Thanks, Amanda.
So for us here at the PQA Annual Meeting, the day is just getting started for our attendees. This afternoon, we will have a variety of sessions that are planned, and they allow you to learn, engage, connect, and collaborate with one another. So immediately following this session, we have 1 hour that is set aside for collaboration. You can visit our sponsors both now and throughout the week by going to the sponsors tab on the meeting website. Here, you can start an instant meeting or schedule a time to meet. If you have questions or discussion for PQA's performance measurement team, they're also hosting office hours that are starting here in just a few moments. And then beginning at 1:30 Eastern time today, we have a series of focused sessions. These 30-minute sessions cover a wide array of topics, and with 3 sessions running concurrently, you can select which ones you would like to attend. Options for sessions are found under the All Sessions tab. An ACPE CE credit is available for these sessions. And then don't forget to join the fun this afternoon that's starting at 3:10 Eastern time with our musical guest and networking reception. All right, this might be my favorite part. As Director of Education, I'm excited to tell you about the promotion that we have this month. Meeting attendees can access PQA's Medication Use Quality Certificate Program for $175, which is a $50 discount on top of the member rate. This 15-hour CE program provides an in-depth training on medication use quality. You can use the code #2021AM. One more time, it's all one word, #2021AM for annual meeting in PQA's Education Center to receive this discount. And with that, I do hope you have a great afternoon connecting with one another, engaging with our focused sessions, and rounding out the day with some music and conversation. And I look forward to seeing you in the online conference halls.
Founded in 1999,